Hello, and welcome to the Making Medicaid Data More Accessible Through Common Data Models and FHIR APIs webinar series. Before we begin, I'd like to provide a brief overview of this project, which addresses the federal priority to expand data capacity or data infrastructure for conducting patient-centered outcomes research, abbreviated PCOR, that informs decisions about the effectiveness of health interventions used in the Medicaid and children's health insurance programs. The transformed Medicaid Statistical Information System, known as T-MSIS, has analytical files that are suitable for research, known as TAFRIFs, as part of a new research-optimized national Medicaid dataset that begins in 2014 with full representation from all jurisdictions in 2016. These files include data on Medicaid and children's health insurance program, enrollment, demographics, service utilization, and payments. This project created open source code to format these data into the FDA Sentinel and Observational Medical Outcomes Partnership Common Data Models to improve data access, accelerate analyses, and enable multi-database studies. The aim of this webinar series is to educate researchers who are using or plan to use Medicaid data about the new data transformation tools and disseminate major findings. Each video in this webinar series is a chapter that covers a key project objective. My name is Michael Stagner from the Duke University School of Medicine, Department of Population Health Sciences, and I'll be leading this chapter, which discusses transforming Medicaid and children's health insurance program data for use with the U.S. Food and Drug Administration's Sentinel Common Data Model. Again, my name is Michael Stagner, and I'm an analyst programmer in the Department of Population Health Sciences, and I work a lot with Medicaid and Medicare claims insurance data. Please note that the views expressed in this presentation are those of the authors and do not necessarily represent the official position of the U.S. Department of Health and Human Services or the Food and Drug Administration. The work discussed in this presentation was funded by the Office of the Secretary Patient-Centered Outcomes Research Trust Fund, which was made available to the FDA by the Office of the Assistant Secretary for Planning and Evaluation through an interagency agreement. The US FDA funded the Sentinel Initiative contract. For this chapter's agenda, we'll be discussing the inclusion criteria for using the source data in the T-MSIS TAFRIFs, establishing rules for transforming the source data into the Sentinel Common Data Model, what the particulars are of running the actual transformation program, and also evaluating the success by ensuring quality assurance on the final product, the final Sentinel Common Data Model tables. The first section is a discussion of including the source data into the transformation process. So the transformed Medicaid Statistical Information System analytical files are a research optimized version of the T-MSIS data, which are submitted by individual jurisdictions. They contain annual files by jurisdiction and plan type, and contain demographic and eligibility information for all the beneficiaries, the claims files that contain service use and payment records, and annual files on the different types of Medicaid and CHIP plans and providers. Please note that CMS periodically releases updated versions of TAF data years as higher quality data becomes available. And depending on what is approved for use, users might expect their data to be slightly different than what is discussed in this webinar. Um, for example, a user may get access to either 100%, the 100% sample of the files, which is what we use for the Sentinel project and what is discussed in this webinar, or they may be using extracts, which are annual files as opposed to monthly files. This transformation also takes advantage of having the status of being a federal contractor, which isn't the typical access provided within the VRDC. It's as we'll see later, there's additional computing resources available and that sort of thing for transforming such a large amount of data. And so if you're trying to run the transformation code, there may be some adaptations that are required based on the limitations for a specific user. So for selecting the source data, the idea is to determine the data quality before any data is even read into the transformation code. And so for Medicaid data, the data quality is prioritized by making sure that there's complete capture for a beneficiary. So that means making sure that if a beneficiary is included in the transformation process, we have access to all their healthcare utilization, so inpatient and outpatient encounters, all their medication and prescribing information, which is obviously of paramount importance to the Sentinel project. And we also want to make sure that that the data are reliable, in that maybe we have records for a beneficiary, but if there's a lot of missing data for the beneficiaries for a certain jurisdiction, then we want to make sure that since the data quality is assessed as poor at that point, that we don't want to include that in the final product because that could negatively impact results of analyses. So three basic steps for exclusions right off the top of the process are person level or beneficiary level exclusions, jurisdiction level exclusions, which occur for an entire state or jurisdiction, and record level exclusions. And those are more non-healthcare utilization records that we'll describe later. So for person level exclusions, we want to make sure that we do include both Medicaid and CHIP beneficiaries, and that we want comprehensive benefit recipients included. So that means full scope benefits or comprehensive benefits. We also want to exclude dual Medicare, Medicaid recipients, since in those cases, the primary payer is going to be Medicare, and the full scope of their healthcare utilization won't be captured in the Medicaid data. Those individuals could actually be analyzed in the Medicare data if you were interested in that. And there's the ability, if you have access to both sources, to link those data, but that's sort of outside of the scope of this transformation process. Medicaid and CHIP programs were created by Congress through Title IX and Title XI of the Social Security Act, respectively. Medicaid and CHIP eligibility includes low-income adults, children, pregnant women, elderly adults, and people with disabilities. Full scope benefits include both mandatory, for example, inpatient and outpatient hospital care, and optional prescription drugs, dental care, physical therapy services. Minimum essential coverage mandated by the Affordable Care Act includes acute care services, prescription drugs, and laboratory services. And limited benefits are usually tailored to specific services, such as family planning or emergency services. The jurisdiction level exclusions are data quality exclusions that are based primarily for our purposes on the interactive data quality assessment found in the DQ Atlas. The website is provided here. This exclusion allows us to determine if a specific jurisdiction kind of has issues with data quality across the board, and are therefore, in our eyes, eligible to be excluded across the board for a specific year. And there may be unique circumstances in which only a year or subset of years for a jurisdiction are determined as poor data quality and they'll be excluded. But then maybe whatever issue was affecting those data is fixed in subsequent years, and so then those years can then be the later years can then be added to the transformation, the final product. And so here's a screenshot of the DQ Atlas, which is an excellent resource. I would say a primary resource for determining data quality in the TAF data. This specific slide shows the data quality assessments for comprehensive managed care plan encounters. And you can see the red is what we would view as unusable. And then there are varying levels of concern, high, medium, and low for other states. And then there's even an unclassified level. So you can see like North Carolina, my home state, in the 2018 data, didn't really have any comprehensive managed care beneficiaries. And so since it didn't have any plans that fell into this assessment rubric, it wasn't included. But you can see that Idaho here and Florida, based on the methodology used by the DQ Atlas, has been assessed as unusable for comprehensive managed care plans. The DQ Atlas topic assessments are by file type, year, and they're version specific. So you can see this is actually release 2 of the 2018 data. And assessment details for a specific jurisdiction, because this is an interactive map, can be found by clicking on a state, which would look like this. Again, so for the transformation process in 2018, comprehensive managed care plan encounters for other services data, which contain the bulk of the data in the TAF RIFs, was rated as unusable due to the low magnitude of records relative to what you would expect, and so it was excluded from the transformation. But in following years, this didn't appear to be an issue anymore, so Florida was brought back into the fold. The DQ Atlas assesses a large number of different topics, and some are related to payments and such, and those weren't selected as topics to use for exclusion for transforming the data into the Sentinel Common Data Model. But this list right here were the ones that were determined as critical for data quality for inclusion. The high priority variables were selected in an attempt to specifically determine whether any widespread data quality issues might exist and would necessitate that all of the data for a jurisdiction year and plan, either fee-for-service or comprehensive managed care, would be excluded from the Medicaid EPL. And the categories of interest include enrollment patterns, enrollment benchmarking, beneficiary information, claim file completeness. So lastly, we have record level exclusions because the TAF data include both service use records, including fee-for-service claims and managed care encounters, and payment records, which are listed here. And for understanding the delivery of healthcare to beneficiaries, service use records are what need to be analyzed. So payment-only records, including capitated payments and supplemental payments, and service tracking records can be excluded from the transformation. The second step is establishing the rules for transforming the source data into the very specific framework of the Sentinel Common Data Model. So once you've decided which are the data that you actually want to use, you extract those data from the TAFRIF. They're transformed into the Sentinel Common Data Model format, which is a series of tables, and each table has a set of variables with specific formats and such. And then those final tables are loaded to a location that can be used for analysis. In the VRDC, we have a specific folder for those tables. And then we receive queries from Sentinel analysts that can be run against the ETL or the data mart. So users with 100% data access or the monthly files will see the same file names as are listed here in the VRDC. If a user is working from extracts, which are annual tables, the names will be slightly different. They won't have these monthly suffixes. And if users are wishing to crosswalk between TAF files and Sentinel Common Data Model files, they're encouraged to review the technical specifications for the ETL for more detail, because the variables won't be a one-to-one. This is the data flow of the ETL process, and this is sort of a little more descriptive than the first slide that we were looking at. But it's taking the original source data files, pre-processing them, which is applying those exclusions, creating intermediate tables, so compiling monthly data into yearly data, and then taking the yearly data and creating final tables from that. Making crosswalks for all the different IDs in the tables across all years of the data, and then here's the list of final tables that we transform for the Medicaid data mart. Here's a list of the entire Sentinel Common Data Model tables. And the first part of the transformation is the sort of core set of tables here, which is demographic and enrollment information, and also prescription drug dispensing and healthcare utilization, encounter, diagnosis, that sort of thing. We also, for the Medicaid and CHIP data mart, create a mother-infant linkage table, which is described right here. And all this information can be found on the sentinelinitiative.org site. This is an example of the TAF source tables and how they are transformed to the target Sentinel Common Data Model tables. So the demographic and eligibility base file that we start with becomes the enrollment file, an intermediate enrollment file, then the final enrollment file for the the final tables. This is a screenshot of the technical specifications document, and so further information would be available in that documentation. The exercise of data mapping allows us to identify potential pitfall or places where there may be losses or mismatches in information. So for example, currently the Sentinel Common Data Model Hispanic ethnicity is set to yes if the combined race and ethnicity value available in the source TAFRIT data is Hispanic. For individuals with a known race value, the Sentinel Common Data Model Hispanic ethnicity variable is set to no. It's sort of an either or. Either we know Hispanic ethnicity or we know race, but that may change with future releases of the TAFRIT data. And here's another screenshot of the technical specifications document. You can see how the target field for the SCDM, this is what we want in the final tables, and this is the name of the variable in the source data. And sometimes we have to pull from multiple variables within the source data, and sometimes the variable in the source data we only need a piece of it, and so we'll apply some programming language to it, or combine it with some sort of information to get exactly what we want in the final tables. So once we know what data we want to use and how we want to get there, we actually run the code that we put together to transform the source data. The ETL code can be found in the Sentinel Git repository, and can be accessed there. The first step is to create that initial set of core tables, which we refer to as the Phase A ETL, and that creates the demographic and enrollment tables as well as the dispensing, encounter, diagnosis, and procedure tables, and the facility and provider tables, which are supplementary tables which can be linked to the data in order to determine facility location or provider specialty. So after the Phase A, the creation of the core tables, you can also run the mother-infant linkage portion of the code, which has to happen after the Phase A ETL has been run and the quality assurance package has been run on it. And part of the quality assurance package is a mother-infant identification process, which looks at the encounter and enrollment and demographic information in the core set of tables, and determines potential deliveries in the final SCDM tables and potential infants that can be linked together. Here's a screenshot of the setup program for the ETL, which allows for new years of data to be processed as they're available, and for processed intermediate data to remain as is, so that if you have new data available, but you aren't changing anything in the way that you actually process the data, you can reuse those years of data that you've already run your code on, and just run the code on the newest set of information, and then combine that all, which allows for a reduced processing time. And here's a table that describes how, when jurisdiction year plan exclusions are determined, we use a little table that helps us determine which data should be excluded. So you can see that for all these years, all of the data for Alabama are excluded from the ETL process. I believe that's due to dual eligibility code. But then you can see for these years of Colorado, we're only excluding the comprehensive managed care data because those are known to be of poor quality. But we want to continue to retain the fee-for-service information since we don't have any concerns about data quality for that set of beneficiaries. So for someone who would want to download the code set from the Git repository and try running it, again, the guidance is that that code has been optimized specifically for this purpose. You know, the 100% of the data and the resources available to us for this Sentinel project. And so some modifications may be required to run the code because the libraries may not have the exact same name. You may not have access to grid functionality in which you can run multiple remote sessions at the same time. So these are all just sort of things to keep in mind if you'd like to run the code. And then finally, once the data are all transformed into the Sentinel Common Data Model, the data quality needs to be assessed on the back end. So, you know, the data quality of the source data was assessed on the front end, and then we want to make sure that everything makes sense once the transformation process is actually complete. So for this purpose, SOC has created a SaaS-based QA package that can be used to programmatically assess if data meet reasonable standards for data transformation, consistency, quality, and are fit for analysis. And they're primarily broken up into level 1 and level 2 checks. Level 1 checks is everything that you expect to be there, the table names, the variables contained in the tables, and the actual values of the variables. Level 2 checks are if the data makes sense. And that's also done automatically by the QA package. For example, the SCDM requires that the variable admitting source in the encounter table is populated only for inpatient, institutional, and emergency department encounters. So if you had some sort of ambulatory visit that had an admitting source value, that would be flagged by the QA package. And then finally, there are cross ETL and cross table checks to sort of check if the data are changing over time. And those are checks that are done by SOC once they receive the results of the QA package. And this is sort of a manual process. But it's strongly encouraged to check how data change over time. And the typical workflow for creating and maintaining SCDM transformed data are the user setting up the environments according to the QA package specifications. The QA packages download from the public repository, and then the user should complete their own comparison to prior runs of the package to ensure data is not changing drastically over time. And this process should be completed every time that new data are added. There's further details on the requirements of the QA package on the Sentinel website, and you can always email questions about the QA package to info@sentinelsystem.org. Nope. I'd like to thank you for your interest in transforming Medicaid and Children's Health Insurance Program data for use with the U.S. Food and Drug Administration Sentinel Common Data Model. If you'd like to learn more about making Medicaid data more accessible through common data models and FHIR APIs project, please follow the links shown in the description field below.